would like to start the next sessions. This maybe take time about 2 hours and more. So here is the one important thing that we need to concern, because we are the operator for the Harlem machine, and it doesn't the normal thing that compare with the normal circulation. So that's why we set up this topic. This would be a physiological change in CPB. The thing that I will talk today is just only the concept. So if you have interest in this point, it's much more detailed, and I recommend you to further reading in the article or any textbook. All right. If you're interested in this field, you can also use this one to set up your research in the future. I would say it's physiology, pharmacology is one of the important aspects for the perfusionist also. So by briefly, I would like to talk about the conduct of perfusion. Actually, it would be a next topic by Ajahn, but I make it like a cartoon, and you can follow it step by step. And if you understand this step before you go to learn, you study with Ajahn, it would be better, in my opinion. Briefly. Secondly, you need to remember about the circuit diagram here. As I have talked to you, we have a diagram from the vena to arterial cannula, what it consists of this diagram. Your role before going to the operation, before you going to move your circuit, connect to the patients, you need to preparations of all of this, like patient information. You get information, you can design your circuit and set up your circuit, prime, set up cushion or a pump calibrate, and verify everything work well. Position the pump and put the line, the tubing line, in the good place. And also, before we take off, like you are the pilot, you need to make a checklist, right? And you can go on the pump, the pump on, or start by part. So here is the picture of our lab that we use the Harlem machine. Inside of this, you're gonna see the bubble trap and also a reservoir and oxygenator. Connect with this table, which is represented for the surgical table. There are a line from the other line that read from the table to the circuit. So on the table there are a blue paper that you see, which is the surgical area. This one is the more seriously sterile area. No, the people cannot direct touch or contaminate into this area. So keep it clean 100%. Okay, so you can see as we have talked in the morning, after we open the tubing set, we're gonna see a machine pack and also the table pack. The machine pack is mean the tubing that we are using to connect the component and everything beside the hollow machine. The table pack is the tubing that we use in operative field. So one side they're gonna keep it in to the saline area, and another side they're gonna send us to connect to the hollow machine area like this. So we are all separate part. After we are already connect between table and hollow machine part together, the surgeon gonna perform the operation by start to a sternotomy, and at that time they're gonna order to the anesthesiologist like him here to put the heparin into the patients. The heparin is function for anticoagulant, and we're gonna talk with heparinization later in the next slide. And after that, the anesthesiologist will be checked how the heparin work or not by using the activate cutting time or ACT checking. Right. At that in that same time, we have a loop called AV loop, which is the using prime solution to make sure that venous line and arterial line in the tables part is no bubble stay in the tip. Here is the AV loop or the line that I have talked to. You see this is the sticker label. It's the blue one, and the arterial is the red one. Connect with the hollow machine part, and most of them is staying on the saline part here, but it's still connect together. And the perfusionist need to run faster to de-airing from this kind of loop. And after that, they will gonna order the scrub will be communicate with the perfusionist to stop the pump. So you can see here, the larger tube is the venous line. The smaller one is the arterial line. They in the preparing state, they connect together. And after that, after we stop the pump, the scrub nut will be cut and break, separate out. One smaller one connect to the gonna connect to the arterial cannula, and the larger one gonna connect to the venous cannula. All right, so and at that time the scrub and perfusionist gonna talk together and the perfusionist gonna stop the flow and put the cam on the venous line. I mean the line at the heart lung machine, and the surgeon gonna prepare the cannulation. In the operating field, the sculptor we will cut line off and separate line to get separate line, venous and arterial line. So after the ACT run go to the 300. Normally ACT a normal value is about 80 to 120 seconds. So after we put the heparin in, we give a heparin to the patient, it's going to be increased. If it increased to 300, it's safe enough for turn on the suction. Once that the surgeon perform the cannulation, there are some blood let out from the vessel. So to recycle the blood, the surgeon gonna order to suction on, and the suction on pump gonna run, and suction will be move the blood go to the reservoir, not jet bypass on. After that, the surgeon will be connect the arterial line with the A line that from the heart lung machine. So the surgeon gonna check the how is bubble pace of the arterial cannulation by asking for the arterial line pressure. So here is the sphygmomanometer that we use to measure the arterial line. Sphygmomanometer to measure the arterial line is measured between the arterial filter and arterial cannula. If it's swing good, like relate to the systolic diastolic of the patient, that means that is cannula in the good pace, cannula tip in the good pace. So that is safe enough to cannulation. And after that, venous cannula gonna cannulate and connect to the venous line. So now we are connect parallel circulation together, like from the CPB and native circulation, right? So we are all ready to move on to the next step. So here, the thing that I show you is the arterial line pressure. It's right here to measure the gradient between the arterial cannula and also the arterial line and the circuit. Yeah, the circuit. If it's too high, it means it might be pressed in that the cannula tip might be attached to the reservoir, or there are some cring, there are some obstruction, so on. And after we connect venous and arterial cannula, the ACT remain running, and if the ACT go to this 400, some reference use the 400 second, and some use 450, and most of them use 480, which is the 4 times of normal range. This is ready to go on bypass. So the perfectionist will be turn on the oxygen blender and sweep gas, and they gonna said go on bypass and time on, and anesthesia will be turn off the fluids. So now we gonna invest. I mean, the CPB gonna invest to the native circulation at that time, and okay, we are not yet take over 100% until we go to the full flow. So now at that time, it's what we call a transition time. Transition periods. It would be because of the hypotension at the time, because balance between blood in and blood out from the patient, it can be because the hypovolemia, sudden hypovolemia, or a hormone change, or a patient response to the new circuit. So everything gonna be dropped down, and the patient pressure, I mean mean arterial pressure can drop down. So the perfectionist need to concern about it, and also because we drain the blood from the patients, sometimes if the cannulation is not good, we not drain as quite poor, is maybe related to the poor venous reservoir level, and make a list of air bubble. Yeah. So you need to observe the venous line blood color and arterial line blood color, because after we exchange the blood through the membrane, it should be convert the dark blood into the red blood, right? And our monitor like see a heart wave, and also the venous saturation need to be considered. So here is during bypass. We need to maintain, just for example, parameters like this. During the bypass, the anesthesiologist will be communicate with the team, and also perfectionists also. We gonna increase, I mean, take off, like your pilot take off the plane into the full flow, like full flow that we calculate from the BSA multiplied by cardiac index in at as we have talked in the morning sessions. So we usually use the cardiac index at 2.4. I will show you later in the next slides. And after we can maintain in the full force state, the anesthesiologist will allow to stop the lung ventilation. That means turn off the ventilator. So now the perfusionist and the Hala machine and CPV take over 100% of the native circulation. So the main function, like heart maintained by the arterial pump, to maintain the mean arterial pressure. The oxygenation or gas exchange will be maintained by the oxygenator. So you need to monitor level alarm. I think Ajahn Noshana will tell you later. Like this high pressure alarm, and its cause you can read by yourself. Okay, let's script this one. And here is the other monitor that we use during the CPB: bad gas, electrolyte, ACT, blood sugar for some team, like urine output to make sure the perfusion, like we expect that if we run and the patient has a good urine output, that means we can provide the good perfusion to the microcirculation. So the urine output from the renal can be represent the microcirculation functions. So if it's good in this range, it's gonna be referred to good perfusions. Here is the poor urine output cause might be related to the condition, might be related to the procedure mistakes. Okay. After the operating done, we're gonna winning CPB. So before we winning with CPB, you need to rewarm the patient back to the normothermia. You need to check your blood gas. You need to check everything in the lab, right? And before winning, surgeon need to de-airing and so on. Everything. Check the breathing. Check the de-airing from the heart. Okay. And the team should be concerned about the other drug support, like inotropic drug, vasodilator, vasodilatation drug, and so on. And if everybody ready to landing, the perfusionist gonna perform weaning. Imagine that once that we divert blood flow out of the heart gonna empty, right? So there are no volume put inside the heart much. When you're weaning, that means you are filling the volume back to the heart and decreasing the arterial pump in the same time. You need to balance together, like put the volume back, decrease the pump, after you put the volume back, the preload of the heart will be increased. After the preload in the proper level, like volume enough, the heart will be generate the good cardiac output by itself. So after the cardiac output push out from the heart, you can decrease the arterial flow, the arterial pump flow, because now heart can be moved by itself, right? You need to wean slowly by slowly, like just a little bit, put the volume back, a little bit decrease the pump flow until it's nearly to stop, like 20% support or 10% support, that is safe to landing, that is safe to separate or stop the pump. Yeah, okay, this is all. So after we stop the pump, or after the pump winning to the half flow, anesthesiologist gonna return to turn on the ventilator again, right? So now the patient native lung gonna back to the function again, and we go forward to breath in and flow down. Yeah, and there are many parameters that we need to check in the monitor, like arterial blood pressure, venous pressure. Okay, if we can maintain in the normal range or acceptable range, we can pump off. And if we have pump off, as you told me, I told you previously, 20% of flow, or a cardiac index about 2.5 flow about CI 0.5 like this. So you can stop the CPB and heart and lung of the patient can work itself or work under the drug support. So now they can off, and one of the important thing in this time is that anesthesiologist will be giving heparin levers by using a protamine sulfate, and the protamine will make it's an antidote of the heparin. Heparin function for maintain to protect the blood clot. So so it's gonna make bleed or any cry of the blood loss. So to protect that, we need to some drug to reverse the heparin function. This drug called protamine. So the protamine gonna work after that, and once the protamine into the patient, pump could be stopped. Everything, no stack the protamine to the system because it's gonna make a clot in the CPB, right? So here is the general step of the open heart surgery with the CPB. The thing that I don't tell you is about aortic cross clamp and also the cardio PGR given. So we're gonna discuss about that together in the next chapter. Okay, that you say we are responsible for take over the heart and lung function, right? And also maintain the physiologic status as much as we can. So any mistake gonna let's say it might be harmful. You're gonna concern about that, but don't be afraid that you need to train and you need to learn a lot before you go to a first pilot or a first perfectionist. So let's see, you are in the track of the training. So if you are in the real situation, I'm very confident that you can do it in the future. So back to our strategy. Because of the arterial pump, as we have discussed, is a take function over the ventricular, especially for left ventricle. So the main function is that it's gonna maintain mean arterial pressure. So why? Because each tissue has its own demand. So what is it need? It needs oxygen, and also the nutrient, also the hormone and everything. So we are a perfectionist, and CPB can be do that. And also the oxygenation and gas exchange gonna flush out the carbon dioxide, and also giving the oxygen. Here is the transport system by using the artificial circulation. Okay. So let's say the flow is related to metabolic support to the patient. All right. Wow. This one is just no, or it should know, or no, it's just no. That is distribution of the blood from the cardiac output to each organ system. So you can see that they distribute to the every organ in the body. So what happened after the CPB on? Okay. All right, back to this concept. CPB, mechanical support, take over function of the heart and lung, and maintain perfusion to organ and tissue, and the surgeon need the blood-based surgical field. The oxygen delivery is dependent on the cardiac output and also the hemoglobin concentration, and the oxygen that we supply from the blood that we provide from the CPB. So cardiac output now we have both from the native part and also the CPB. But once that you stop the heart, the patient heart, that means the full support gonna be a CPB. So cardiac output from the CPB is take a function for this oxygen delivery also. Also, we have dilute the blood for the patients. So the priming solution or substitution solution gonna cause the reducing of the hemoglobin also. It seems like anemia in the short time, in the short period of the CPB run. So this is the basically pathophysiology from the CPB in terms of oxygen delivery. And another thing is that we have 4 strategy. I put the 4H strategy using in the CPB called several effects. One is because the artificial surface of CPB can cause the blood clot and cause the obstruction of each component. So when we let the blood out of the body, because it not same like a vessel wall, the blood gonna clot automatically in some time. Same as you connect the patient to the CPB circuit. Blood tied to itself to clot by coagulation process. As you have learned as a second year, right? So to protect that, we need to giving some drug to stop the process. We call giving the heparin, and the patient got heparin. They are go to state of the heparinization. This is the effect to the procedure also. And the hemodilution, at the past, they use the whole blood from the blood bank to prime all the circuit. We cannot allow the empty tubing, empty gas go to the patient, right? So we need to fill this kind of circuit by using some fluid. At the past, they use the whole blood. So imagine the whole blood. When you donate the blood to the blood bank, it contains a lot of cells and contain a lot of the component, right? How many units that you need to prime in the one case? It's too many, because the total volume in your body, let's say if I am 70 kilograms, it's gonna be multiplied by about 75. So about 5 liters in my whole body blood volume. So if we use the blood a lot like that, like a 2 or 3 liter, imagine how many people need to donate, right? Secondly, if you use a lot of transfusion blood, it maybe take a risk of infections also. Thirdly, if you use the high concentration of red blood cell inside the blood priming, it's gonna be cause easy to hemolysis, right? Because there are a lot of content in that kind of fluid in the circuit. And another one need to concern is that blood viscosity. If we had a high viscosity, it's not easy to go to the microcirculation. So that's why hemodilution strategy gonna take place of the whole blood priming. Okay, the next thing is hypothermia. Because we are we're using the artificial circulation, right, to make sure that the metabolic balance gonna okay. If we reduce the temperature, body temperature, it's like a polar bear in need to hibernations. Sometimes they no need much like metabolic rate in the cold better. Same like that. If we put the hypothermia, if you put the patient to the hypothermia state, the cell gonna use less energy or ATP than the normal thermia. So if we reduce the hypothermia, we gonna flow. We gonna make sure that perfusion gonna supply to the tissue. And the fourth strategy is heart protection, because the heart is like so now we do the heart operation, right? So by the surgical itself, it can be trauma to the heart. The surgeon need to cut and make a scar or make a surgery and so on the heart. That is hurt the heart a lot, also injure to the heart a lot. So our law as a professional, you need to protect the heart also. The one thing that we use is by giving this cardio procedure to stop the heart. If we if the surgeon perform the heart while the heart pumping, it's not easy to put a seizure. In other words, it also make the risk of injury. So to protect the heart is one of the strategy that you for CPB. However, if too long, if we stop her heart too long, or increase, let's say increase the ischemic time or period, that means the heart don't receive the blood for some periods, it's gonna make some necrosis or ischemia in the same part of the heart muscle. So after you wean the pump, it may be irreversible for some patients, right? Okay. Go back to the hyperinizations and the protective blood clot. So here you see the breast contact to artificial surface is gonna activate the protein plasma functions. The main system are the platelet. Platelet gonna activate, and the platelet gonna go to aggregation and then come together to try to make a group of them and make a thrombus. And coagulation activation, also the clotting factor gonna come together. So the other side is complement activations, which is related to inflammatory response. As early causes that we have a special topic from the Professor Gore, that he has talked about it, how to protect and how to reduce the inflammatory response in the CPB or extracorporeal system, right? And this is a process that's always occurs from the extracorporeal circulation. Any extracorporeal circulation, even in not only in the CPB, it's also in the hemodialysis for renal failure patients. So heparin is the take function to stop this process. Okay, I have reviewed some lecturers have talked about heparin already, and I'm gonna go further in the next step. So here is the machine we call the ACT. It's gonna count the heparin how many seconds that it's gonna be correct. Normally, we have the ACT length about 80 to 100, 120. But after we give the heparin for go on bypass or go on CPB, we need a four times of the ACT. So here is the as early hemodilution strategy that I just explained to you. So we need priming solutions. A priming solution is generally known for the perfusionist, but it's actually a substitution or replacement fluids that using for priming the CPB. So here is the whole about disadvantage. And here is the historical a timeline that they turn to the whole bus into the using the other solution. All right. The advantage of hemodilution that I have talked to you in the previously, that you see the blood viscosity will be reduced and improve the original or a microcirculation flow. Right. And decrease the blood bank need. Anyway, the hemodilution gonna affect to the pharmacokinetic and pharmacodynamic of the agent that's given from the anesthesiologist and us, because one thing is dilute all the protein in our plasma, right? The second thing is that it's also dilute the drug that we give for the patients. Sometimes we need we can not say that this the not used in the normal dose as the normal people. The hemodilution also improve the neurologic and renal and pulmonary perfusion, so the outcome is quite well. But the perfusionist need to concern and no dilute much until until decrease not enough hemoglobin. Right? You need to concern that, because if not enough hemoglobin, there are no carrier for carry the oxygen also. So you need to balance about how much hemodilution, how much the flow, how much the temperature need. And you also need to maintain a good arterial blood gas, also the blood gas measurement. The next thing is that hypothermia. The hypothermia is the early strategy that used for the heart operations. In the past, they put the patient into the into the ice bath like this, and put the patient inside of this, and let the temperature down, and perform the surgical after the hypothermia. So we can cool down. Let's say cool down until we make a totally stop the circulation, right? I mean, no need for a CPB flow support, no need for heart pumping support. If you have seen in the movie scene called Captain America, that he stuck in the container or something, like container in the cold container. They're freezing on him on some storage. I'm not sure. I'm not a big fan of Marvel. But after that, they reform the Captain America and bring him back. The same concept like that. In the past, we put the patient into the ice bath, and it can stop the circulation and perform the heart operation. Okay, so it can be classified the how much hypothermia. So you can see the mild, moderate, deep, and profound hypothermia. If you cool down to the profound hypothermia, you can stop the circulation like a safety margin at 1 hours. For the deep hypothermia, it's maybe 45 minutes. Moderate hypothermia, you can stop everything for the half hour. So you can see in this graph, this is the temperature reduced in the dogs experiment. So you can see metabolic rate gonna go down. So this is the main objective of hypothermia. Okay, all right. The next thing is that heart protection. We have protect by using the cardio pressure, which is the next topic in the next week. Basically, the cardio pressure is high concentration of the potassium. If we put the potassium directly to the heart, it can cause heart stop. Another strategy, because we use anesthetic agents and also so on, another procedure can also preserve for the heart. Okay, how to monitor? So I'll come back to for strategy again, and this is a definition of CPB again, and like step of operation. From the cartoon, we scripted one. We script the arterial cross clamp into the declamp, which is that we stop the heart. So the main point of pathophysiology of CPB is that the CPB is the perfusion system. Secondly, the CPB is the oxygen exchange or oxygen delivery system. So we need to concern about the adequacy of the CPB and also event that triggered by CPB. Firstly, from the CPB as the perfusion system, I would like to separate. Actually, I take from the textbook or a paper. I can't remember because I didn't. My fault. I didn't put the credit into my slide. So if anyone find this article, please send it to me. Okay. So the CPB as the perfusion system. Because we need to maintain metabolism to certain patients, cardiac output, the oxygen delivery, and metabolic waste to need to watch out. Normally, it's related to this kind of factor. So it's gonna control by using the autonomic tones, autonomic nervous system, and also circulation hormone. But on the CPB, the cardiac output is equal to the blood pump flow. So it's kind of said the 100% takeover because it's partially because this is the artificial one. So it's related to the patient response itself. Some of patient response itself, and also we need to help the patient because now patient in some condition that is not normal, it's unusual condition, right? So to AC, you can giving the drug to drive the vasopressor or a vasodilator to the patient to maintain the SVR or a muscular tone. So the next thing is systemic blood flow. As I told you, the pump flow is the hollow machine. It's maybe related to the patient size, age, temperature, depth of anesthesia, and hematocrit. So here is the example for the temperature change and bypass flow rate that they need. Here one is this cardiac index. You can compare with the patient temperature here. So if you reduce the temperature, you can reduce the flow also. Another thing is that metabolic need is different by the patient aging, like a smaller patients, you may need a lower mean arterial pressure during the CPB, right? When we running the CPB, one of the parameter we need to concern is arterial pressure. So from the basic physiology, MAP gonna lead to the cardiac output and SVR, as we have talked in early. The cardiac output gonna drive by pump flow, and SVR we can use the drug like vasopressor or vasodilator drug to maintain the SVR. So I'm surely that Ajahn Nushna will be talk about SVR later. Okay. The next thing that's gonna affect to the arterial pressure is that blood viscosity. So when you cool down the patient, but viscosity will be increased. Right? Does it make sense? But however, you have induced hemodilution by using the priming solution. So viscosity might be need to balance. And also, if you make a like more dilution, like increased dilution, it's gonna cause the arterial pressure decrease because of but viscosity is reduced. Yeah. The smooth muscle tone in the arterial or vascular tone, because when you are running the CPB, it's almost used in the non-pulsatile form, right? Imagine that we it's it doesn't like heart, because heart pump, there are the system systolic and diastolic, right? Heart pump move relax, contract relax, contract relax, but the arterial flow is cannot do like that. The flow gonna be a non-pulsatile, no waveform. It's like flat line. So the vascular tone cannot respond to this much as the normal state. So it's affect to the further condition like this. Yeah, and also affects from the anesthesia, drug agents, hormone, acid bed, and so on. Does it make sense? The one important thing is that inflammatory response. Normally, the SIR or inflammatory response or SIR during CPB can cause the vasodilation and cause the BP drop. So that the thing that relates to the arterial pressure that maybe occur during CPB. In the other side of the pressure, which is the venous pressure. The venous pressure represents the blood volume, and venous tone are the same as the previous one. Okay, so venous cannula gonna perform to separate the blood from the patient, right? So it needs to check the press, size, clink, and not disturb the heart position much. And we not return gonna be good to decompress the heart and also to make sure all of the blood gonna back and waiting for the exchange. So we not return is the one of the thing that we need to consider a lot. Distribution of the blood, as I told you, normally in the normothermia in adult, we keep the normal flow at this cardiac index of 2.4. And here is the progressive radial after we reduce the perfusion from the visceral organ first, like Hispanics, renal, and then the cerebral blood flow. So we need to keep all the functions of the organ. So it's not a extra like it's not an extra complication I mean, the patient no needs the extra complication from 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 the operation. So the thing that we need to concern the perfusion in every organ. So the hypothermia can be helped to reduce the flow. All right. I think I have talked about transition period between the native circulation into the CPB circulation. That's maybe because the patient immediately BP drop in the normal or adult healthy, the patient without the underlying, the heart patient with no neuro complication, with no DM, with no hypertension, it's gonna be okay. But if for some patient who has the previous history about stroke or any some kind of ischemic event, the pressure drop for some short periods, it can be caused the serious conditions after that. So we need to concern when you are the perfectionist, you need to balance, take off the aeroplane like a more smooth as you okay, to save the patients. So this is the onset of the CPB. The SCR is going to be changed, but viscosity going to be changed, vascular tone is going to be changed. So the flow from the CPB gonna slowly invest to the native one. So the condition change from pumping itself to controlled by the CPBs. Circulatory during the hypothermia. Okay, after the hypothermia, imagine that the hypothermia coming. Normally, SVR gonna increase because of the vasoconstrictions. Yeah, the hypothermia need to observe and balance between perfusion and hypothermia. And also, one important thing is that viscosity will be increased and rising the hemolytic. So you need to concern and balance hypothermia, metabolic needs, and the hematocrit. Okay, the same thing, decrease SVR, it may be occur also. Some increase, some decrease, it depends. The flow rate gonna be lower in hypothermia. I said that 1,000 times. Right. During hypothermia, it may be a bit more mean arterial pressure can be decreased, and then you can use the previous slide as the chart referring, because now every organ preserved by the hypothermia. One the organ that we need to concern is that brain. Brain hypothermia can be said that it's will preserve because the brain metabolism will be reduced. If there are something happen to the brain, it's gonna be okay. So let's say the term of in terms of the auto-regulation. You know auto-regulation, right? So the auto-regulation will be shipped like so it's allowed to lower mean arterial pressure to support to the brain. Okay, but after we cool down the patient, we need to rewarm back, and this is more serious. Imagine in the hypothermic period, every protein gonna be suppressed because of we need to because of the cold temperature can be stop the protein function, right? But after they receive the temperature, it might be caused the overexpressions. So the SVR sometimes is overexpression and resistance gonna like reduce too much, and because the hemodynamic drop or MVP will be decreased. Okay. So also the SVR and mean arterial pressure maybe reduced again after decramping because reperfusion and metabolic and free radical can be caused the SVR is decreased. Right. All right. Imagine that we stop the heart, but inside the heart there are still functions for some function, like heart muscle. Every function has their own waste product, but it cannot go out after they receive after the tissue receive the blood and nutrient again. It may be caused the free radical. It might be caused the over expression of this response. So this kind of waste product, this kind of free radical can be caused the change in the vascular tone and tend to be the reduced SVR and tend to be to make a mean arterial pressure drop down. At microcirculation and tissue perfusion, we also need to concern about that. Because it is the thing that difficult to monitor. But the one of the biomarker that we use is that lactate level, and so this kind of response, you need to put some drug and use the like a diuretic drug to let the excessive fluid out. And some institute they use the pulsatile perfusion. I mean, they can run the CPB by using a pulsatile, but not all the procedure. Like they have inclusion criteria, like some patient who suffer with the renal failure, they're gonna put the patient into the pulsatile CPB, something like that. Or sometimes you just giving the anti-inflammatory strategy like using the filtration, using the steroid drug to preserve this response. Okay. 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 For microcirculation, it's related to the hypothermia and related to the hemodilution as I explained in this one. Okay. Here is the waveform that I just taught you. The waveform A is the normal positive flow. Okay. Secondly is the flow, but different in the not of there are two peaks, right? In the picture A. The peak one is the systolic. The second one it might be dichotic knot. I'm not sure, but here is after you run on the part with the positive flow, you just have one peak and one like a sine waves here because we cannot generate the dichotic knot like normal people, but the most of CPB run we're gonna see the flat line like this, so that means there are no hostile at this this procedure. Okay, they believe that the positive flow gonna help the patient with suffer with the microcirculation problem, like renal failure patients. It's gonna be improve the renal output during the CPB, something like that. You need to train to perform this one first if you want to perform the positive flow. But for me myself, I have no experience much about this because by my practice I use only the non-positive flow. All right. Previously is the perfusion system, the support from CPB. The next thing is that CPB as the oxygen delivery system. So oxygen function is the lung, artificial lung, right? So we need to monitor PO2 and PCO2 or bad gas for the maintain its functions. Here is the value of the arterial bad gas. I put it that for a reference for you. So here is the sweep gas in the white color, and the other side is the FiO2 of the percent of the oxygen that we give to the CPB system. So how much adequate of the perfusions is depend on the temperature. It depends on how deep of anesthesia. So to maintain adequate delivery of oxygen, you need to concern about this point. However, you need to avoid activation of some reaction like straight or ACR. You need to talk with anesthesia to give some drug to preserve that. Okay, so from this graph, you're gonna see the oxygen consumption, which is related to reduce the temperature. So you are the perfusionist, you need to provide adequate perfusions. A global monitoring, you need to observe the oxygen consumption or SVO2 measurement. Normally, we suggest to maintain about 80%. We are not common use the oxygen delivery, but we can use the oxygen delivery equations to explain everything that I have talked in the early. SVO2 is here, is the inline monitor of the venous saturation. It's quite common use in the CPB. The other thing for the brain function is maybe need the brain ultrasound on CPB or a Doppler. I mean the flow measurement to the brain during the CPB. For some patient who has feelings on the stroke or neural complications. And renal functions is mainly monitored by urine output. Very simple for renal functions. We're gonna maintain 0.5 to 1 cc per kilo per minute. Okay. Here is the effect that triggered by CPB. So many effects that occur during the on CPB, right? So as you see, there's this diagram. Yes, so many. We can talk. We can talk about that in this time limit, but I just show you for the idea of how the effects in every organ from the cardiopulmonary bypass. Okay. So adverse event can be triggered by the CPB. Let's start from the hemorrhagic condition because it's directly from relate to the blood system. So the blood content, the plasma, everything so on can be changed between the CPB. Okay, so red blood cell gonna be changed to like trauma. It's gonna become stagnant and less distendable. Hemolysis, we no need hemolysis, and can be cause hemoglobinuria. So the urine, patient urine is gonna be converted to the Coca-Cola color or something like that. That is a site of hemolysis that occur for the CPB. A leukocyte and a platelet gonna easy to activate during the CPB also. Okay. Plasma protein, because we have hemodilution and also blood direct contact, but direct surface interface effects. I mean, blood direct to contact to the artificial surface, so it's gonna be respond. We call this response is a surface interface. So it's gonna be activate protein denaturations, enzymes, aggregations, solutable, and so on. And its effect to colloid osmotic pressure. This is the one of important thing. I will talk about colloid osmotic pressure in the next part of the hemodilution, because if you reduce colloid osmotic pressure, the intravascular volume gonna it's gonna easy to leak out to the tissue. So if that volume leak out a lot, it's can because the patient go to the edema. Edema is in Thai we call bwom. So tissue gonna contain a lot of fluid than usual. So imagine if it leaks in the visceral organ, like internal organ. It's gonna be cause the organ functions bad, right? So this kind of thing that we need to concern a lot. Every process gonna activate also coagulation, fibrinolysis, complement system, is a systemic inflammatory response, and so on, activate from the CPB. Here is the thing that I just talked to, like if the capillary has fluid leak out from the intraocular volume, like it shift to interstitial tissue. And it's gonna be cause the accumulate of the fluid inside the tissue and cause the edema. So to maintain that, you need to balance the oncotic pressure to hold the volume inside the vessel. All right, effect to the heart and effect to the brain. Okay, heart gonna be stunning because you will need to stop the heart and giving the potassium to stop the heart. So that it stopped, but it's some parts of them. Let's say it's about one out of 4. The cell function remain function. And once the cell is remain function, is still using the ATP and also make the waste product, as I told you. So after we reperfusion again or give it back to the heart again, it's gonna be maybe cause the heart like function unwell. The CNS is one major concern, but let's say there are 3 points. One is the hypoperfusion. If you not provide good flow enough, the metabolic rate is gonna less than higher than your support by your CPB. So this is a hypoperfusion. Second thing is that thrombus, emboli, or anything that's floating from the blood flow to obstruct the vessel. And inflammatory response can cause the malfunctions of the vessel wall and can cause the edema. So it needs to concern, especially for the brain, because it's not easy to return brain. The renal, as I told you in early, renal can be just only monitored by observe or maintain on the urine output, but for some people even that we run a lot of flow, it cannot improve at all because they have a condition before go to the operation. Like they have a condition like renal failure or something like that. Some paper recommend to use the positive to improve that one. Another thing is hemoglobinuria. That means if you see the color change in the urine, as I told you, it's gonna turn to a Coca-Cola color, or maybe red color. That indicate the hemolysis gonna occur during the running the pump. So yes, oxygen testing, hemodilution, and so on need to be concerned. For the visceral organ, it's also sometimes need to concern also because the microcirculation is quite difficult to monitor, and it's not normally we didn't use the like a monitor for this kind of organ. We just expect if urine output is good, other organ gonna be good also. Right? But we're gonna find the effect after the patient go to the post-operative period, like in ICU and after they go home. This is the visceral and other program, the other organ. So the risk factor gonna include the patient condition, cell, like, and also the advanced aging. All right, here is the cytokine, endocrine, also the same. Okay. Okay. What up? Okay, sorry. I feel like I sleep a little bit. I think some guys had already sleep now. Right. So, okay, back to my presentation. The pulmonary function, because we use hemodilution, we use the artificial surface, so the pump can be cause the edema to the tissue, right, and respond to the artificial surface. So most of the side effects that found in after the CPB is that the pulmonary function is go bad. The one thing is that we usually find the pulmonary edema because of the capillary content a lot in the lung, and the lung has the soft tissue. So the food is easy to leak out from the lung capillary and cause the pulmonary edema. And we call this term as pump lung disease, pump lung disease. So some in the early of this heart surgery, they found a lot, and the pump lung disease they found after the operation, like a patient in ICU. After that, they make an X-ray film for the patient, and they found the water change in the lung a lot. So here is it is the pulmonary disease. All right. Inflammatory and immunological effects is one of the thing that's always occur because we cannot avoid it much. It still occur because if you remember about it, Dr. Gore said about inflammatory response, you can reduce by using the filter, you can reduce by using the shutter circuit, and so on. So here is the consequence of this process, if you remember. Right. All right, the new technology that used to prevent this effect is that coating inside make the surface like normal people, normal human as much as they can, like using the coating material, using the filtration, using the drug like a steroid drug to prevent the inflammations and so on. All right, that is all for today. Hope you can follow me. And any question?
I think not right now.
So I think you may need to digest about that. You can ask me or Ajahn Dongchana about this kind of, or Ajahn Suphapon if you have a contact to discuss with them. I think the perfectionist has an answer for you. So so if you have a question, please leave your message to me. Okay.
Of course.
โอเค ถ้าไม่มีอะไรก็มี if you have a feedback, feel free talk to me. Like I happy to receive your feedback. Okay, so no worry. Okay, any questions? If not, we're gonna go now. I'm gonna go now and see you later in the next chapter. All right. Hope you enjoyed today, and hope you have hope you have a good weekend. All right. Goodbye.
Thank you
ขอบคุณค่ะ ขอบคุณค่ะ
ขอบคุณค่ะ
ขอบคุณค่ะอาจารย์
ขอบคุณค่ะอาจารย์